All right, I think maybe let's go ahead and get started. All right, I'm here today to talk to you about an important topic, diabetes in a diabetes value-based care in a value-based world. And just want to point out that this is a recorded session. It is one of many of our Lunch and Learn program, and I wanted to be sure that you understood we can go back and actually access any of these recordings in the members and resources section at the web link that's listed below. Next slide. So we all know that closing gaps is hard work. And in fact, I'm sure that all of us feel pretty tired, and that is an intended pun in the photo. That sometimes we feel like we're pushing uphill, and that it's just really hard work. Next slide. But I can also say that if there's a plan and if there's teamwork and if you have the right tools, that we can often bring our patients, next slide, to the finish line, and we can cross that finish line together. That finish line may look different for every patient, but if we follow the rules and we try to work as a team, that we really can cross that finish line. Next slide. So my objectives today, I want this to be a somewhat interactive session, and by doing so, if you do have two screens or two computers, you're welcome to follow along, keeping me up on one screen and going to Healthy Intent registries on the other screen. But if you don't have that capability, don't worry, because what I would like you to do then is when you have the recorded session, try it again with the recorded session, and then just follow along using the recorded session when you do have two computers available. So we want to identify which of the measures that are diabetic based are value based, because I know that providers, staff, we have a lot of measures in our diabetic registry. And what we're trying to do is not overwhelm you. We want to try to scale that down and let you know which measures are most important, because we have so much work to do. And sometimes it just feels like we're swimming in muddy water, and we really need to know which ones to concentrate on. So what I'm going to point out today are the value-based measures for our ACO. Not for every ACO, but our ACO that we really need to concentrate on with our patients. Next. We're going to provide some detail on each of these value-based quality measures, including inclusion criteria and exclusion criteria of each. We're going to examine what methods we can use for gap closures for each of those value-based measures. And lastly, we're going to apply those, if possible, to examples that you have in your own practice, because I don't know about you, but I always find that when I'm learning something, that patient examples or case studies are the easiest way to make this real for you. And if you have a patient, specifically one that's not well controlled, and a diabetic who's not well controlled, using what we learned today to apply to that particular case is a really good way to learn how to go about this. Next slide. So the tool that we want to use is the Healthy Intent Diabetes Registry. Soon, and actually I think it's coming very soon, they're going to rename this as the Oracle Data Health Intelligence, but I can't, that's a mouthful for me, so I'm just going to leave it as the Healthy Intent Diabetes Registry today. So what is a registry? A registry groups patients with certain criteria together into a population, and this allows us to monitor their care and their outcomes, and then to apply interventions that are based on the findings that we have. Next slide. And what is a value-based measure? Well, CMS and the insurers know that if we adhere to these measures, that this results in quality care, and that translates into improvement in outcomes, which then for them and for patients may increase cost savings. So that's why the insurers have such a big game to play here, is because they want to save money. And so do we. I do want to point out, though, that it's very important for us to keep in mind that the goals that are identified in quality measures are not always the same as the goals that are set by clinical guidelines, such as the United States Preventative Services Task Force, the CDC, or other guideline entities. So what's clinically recommended for your patients might not always be recommended by your value-based measures. Especially frequency, for example, might not be the same. All right, next slide. So when we look at quality for diabetes, for quality in general for our ACO, we look at three main categories. So the first category is the MSSP ACO measures, and those are mostly our Medicare patients. So those are the top 10 measures that we have, and those are specified for our Medicare patients. The HEDIS measures that you're going to hear everyone talk about are mostly for our non-Medicare patients. There are a lot of HEDIS measures in 2024, but we are given a certain subset of those HEDIS measures that we have to comply with at our ACO. And we're going to go through some of those that are applicable to our diabetics. And the third area of quality that is very important to our ACO are the star ratings and the HCAP surveys that we have, that our patients get. So let's go to the next slide. The next thing you need to know about is benchmarking. Well, I think we've all been at least affected by benchmarking in our lifetime, because we've all been that little boy who's very proud of how we benchmarked against others in our classroom. But we've also been the other people at the table that are looking at that little boy's report card and thinking, wow, I wish I was doing as well as he did. So benchmarking for our ACO is how we are scored compared to others who are doing the same thing that we're doing or trying to do the same thing that we're doing. So we're compared to our peers. And this determines our shared savings opportunities. And what does that mean? Well, if we take care of a population of patients and we're able to save money for Medicare, then Medicare is going to give us some of that money back. That's how that works. So the question is, did we actually provide better care than the benchmark? And if we did provide that better care, were we able to show that by providing data in our submissions? So it's not just actually doing the better care, it's actually being able to show that we did it. And that sometimes is the hardest thing to do. Next slide. So this year, the team at the ACO looked at all of the diabetic measures that we had in our diabetic registry. On the left-hand side, you're going to see the old list. And we felt like a lot of this was overwhelming our providers, and it was making it so, okay, so I see all these measures, but I'm not sure which ones are the most important for the ACO. So which ones do I have to concentrate on? And I really don't know what to make this patient do, because those of us in primary care know that sometimes it's really important just to give the patient one or two things that they have to do today. So on the right-hand side, you're going to see that we have whittled this down to the ones that are value-based, the ones that the CMS and the HEDIS scores that we are responsible for shared savings on. So the new list is on the right. All right, next slide. So you're going to ask me, how did we do on all these value-based measures in 2023? And I tried to do this in a pictorial fashion and bar graphing so that you could see from the colors how we did. So orange is, I'm going to start back again and say that blue is good, orange is bad, with exception to the one inverse measure in the middle there. So you can see that we've got a lot of work to do. So next slide. So what's the tool that we can use to help our team in making this better for our patients? And the tool is Healthy Intent and the registries that we have. So how do you get to that? Well, you log in, in this slide, you're gonna have this, and it's gonna be on the recorded session. So you go to the West Virginia Health Network website, and you then log into Healthy Intent. and then to registries, which you see outlined in pink there. Next slide. Then you have to select your clinic or organization. So you go to the search bar, the search menu, and then you find your clinic. Select your clinic, and then you go over to the right-hand side and change it to the grid fashion, which I just do that because I think it's easier to look at. So next slide. So now you're looking at all the registries that we have. And now you want to select the diabetes registry. So you're selecting the diabetes registry for your particular clinic. Next slide. Now you're down to the diabetes registry and you're seeing all the different measures that are possible in the diabetes registry. And here I've selected the first one that we're going to talk about, which is the hemoglobin A1C poorly controlled greater than 9. And this is an inverse measure. But what you're going to see is, how we're doing with the percentiles in my clinic. And then you're going to see down at the bottom where I have circled the view filtered persons. And this is how you get to the actual people in your clinic that are having a problem with this particular measure. Next slide. And this isn't exactly how it looks because I can't put any HIPAA protected information on these slides, but in yours, it will look like there'll be patient list over on the left side. And if you select a particular patient, you will see all these blocks show up on the right side. And you can see that this patient had a hemoglobin A1C of 10. So he's not doing very well on this particular measure. Next slide. When I select that block, I can see that the hemoglobin A1C was actually done on December 28th, 2023. And it comes from my Millennium EMR. I can see the source of the data, and I can see the date that it was done. If I click on the measure details in blue there, the next slide will show up. And this tells me what it takes for that patient to be in the numerator of that particular measure. And in this case, we don't want them to be in the numerator. So this is the number of patients who have an A1C greater than 9 or an average glucose of greater than 212. And it's always the last reading in the performance period. So that's an example of how I'm using the tool to find the patients who are not doing well on my measure and finding a list of those patients. All right, next slide. So I want to look at the 3 measures that have to do with hemoglobin A1C. There are 3 of them. I'm going to point to the one in the middle first. This is the hemoglobin A1C, yes or no. Well, this is a measure that is just looking at whether or not you did an A1C on your diabetic patients in the performance year. It's not the actual measurement. It's actually just, did you do one, yes or no? The second measure is whether or not your patient who has diabetes has an A1C of less than 8, and that's a HEDIS measure. And then the last one is the one we just talked about, which is an A1C greater than 9, and that's the Medicare MSSPACO measure. And this is an inverse measure. We're going to go through each one of these. Next slide. So that first one just looks at age 18 to 75 diabetics, and they just have to have an A1C in the performance period. The second measure, the HEDIS measure, it looks at diabetes patients who are 18 to 75 and have a diagnosis of diabetes, and they want to see if their blood sugar was less than 183 or if their A1C is less than 8 in the performance period. And then the third measure is the one that is important for Medicare patients, and that's the inverse measure of greater than 9%. And here you can see that Medicare specifies encounters. So it includes all patients who were seen during the performance period for an E&M visit that's new or established, all preventative visits, All home visits, telehealth visits, Medicare, and even medical nutritional therapy visits are included. That patient, if they have an A1C over 9, or if they haven't had an A1C done at all, you're going to see them included in that numerator, which you don't want. Also, in this measure, you're going to see some exclusions, including hospice, palliative care, if they were 66 or above and in a SNF unit or a long-term care facility for longer than 90 days, if they have a frailty code and an admission to hospital or the ED or an OBS, or if they are on dementia medication. And then when they say dementia medications, they mean the old ones, not lecanemab. On the very far side, you can see that Medicare allows us to use some G codes that would indicate some of those exclusions. And I do want to tell you that right now in our registry, we don't have some of these exclusions. The logic for those has not been currently enabled, but we are looking at doing so in the near future. So hopefully that will take some of those people out of the denominator for you already, and you won't even see them on your list. All right, so next slide. This are further details that you need to know about this measure. That age is defined on the date of service. Next. The patient is included only if they were seen for those particular encounter types for the Medicare measure, but doesn't matter for the HEDIS measure. And the A1C, or the average blood sugar, is the most recent value. So your patient can be well controlled all year and then show up with something over 9, and they're going to be in that numerator, which we don't want them to be. Next one. The A1C requires a digital value. Now, this is a big problem because it's not good enough to just scan your outside lab value to your chart. That won't work. It doesn't work unless you manually abstract that number. So if your EHR allows you to transcribe that number into your record somehow, that's what you're going to need to do. Or you need to talk your patients into having the lab done at point of care in your clinic or in a lab that's interfaced with your clinic. That's a very important thing with this particular measure. Next. Remember that the one for greater than 9.0% is an inverse measure. That means you don't want them in the numerator. All right, next slide. So how do we fix it? When we see that our patient is not performing well, what do we do? Yep, the providers and the staff here know that if a patient is not well controlled, this is not fixed overnight. So it's really important with our diabetic patients to start working on this early in the year. Don't wait until, September to start working on these patients because it takes time to fix a hemoglobin A1C. This is a measure of blood sugar control over the last 3 months, not yesterday. So it's going to take 3 months to get it better. So the first thing that you do is you identify whether or not the patient should be included in the diabetic registry. Just this morning, I had a provider who's paying attention to her registries, and she asked, why is this patient in the diabetic registry? She's never been a diabetic. She is not a diabetic. She was overweight and she's on a GLP-1. Someone in a lab had attached a diagnosis of diabetes to this patient in error. And now this patient is in the diabetic registry, but not only our registry, the payer thinks she's diabetic too. And this is a very unfortunate circumstance for us. We can't do anything about it. We can manually take them out of the registry, but if we do that, if the patient becomes diabetic, they will never go back in the registry, which is a problem. And even if we do that, it does not remove them from the payer thinking that they're diabetic. So the best thing to do is to go ahead and do an A1C and prove that they're at least not above 9. That's all I can tell you. In that first line, you're best to just go ahead and do an A1C and prove that this is a patient who's not only not diabetic, but is, below 5.7. Now, the second line, if they are a diabetic and they're poorly controlled, you want to make sure that they've had an A1C recently. And you want to make sure that that A1C is from an interface lab or that you can transcribe it into your record from an outside lab. If that A1C is 9.0 or less, well, you're not happy, but you're at least satisfying the measure. And you can work on that patient further to get them down to 7 or 6.5 or whatever your goal is for that particular patient. If that patient is still above 9, then the providers and the staff need to go to work. So as a clinical staff person, what can you do? Well, you can propose that this patient be seen by medical nutritional therapy. And we're going to go into that a little bit more in a minute. You can also perform a SDOH assessment, a social driver of health assessment, because when patients are poorly controlled with diabetes, there's often an underlying reason. Maybe they can't afford their medication. Maybe they can't get transportation to your clinic. Perhaps they don't have money for food. Perhaps their housing is a problem. And if you can help with those underlying SDOH issues, perhaps their diabetes is going to be under better control 3 months down the road. What can the provider do? So the provider has to treat the whole patient. You can't just treat the number. You need to look at everything. You need to look at what other medical problems does the patient have? Do they have hypertension? Do they have obesity? Do they have fatty liver disease? Do they have obesity and other things like sleep apnea? So you've got to treat the whole patient and decide what the pharmacologic therapy should be based on everything that you see. You also need to know the insurance of the patient and what kind of medication is affordable for that patient. Whatever the provider and the clinical office staff do, you need to have short-term follow-up to reinforce those positive outcomes in particular. And if there are negative outcomes, you need to go right back at it again and do more intervention. Over on the left, you're going to see the G-code star. The G-code star is going to show up in these slides in situations where there are G-codes that allow exclusions. And if your EHR does not allow G-codes, there's always the option to do a manual G-code cheat sheet where your nurses can add a G-code and present that to the coders for those particular patients that allow the exclusion to occur. Next slide. So how do you refer to medical nutritional therapy? Well, every Medicare patient is allowed 3 hours of diabetic medical nutritional therapy in the first year and 2 hours every year after. We have done some pilots on medical nutritional therapy that have shown that patients really enjoy medical nutritional therapy for diabetes. They feel that it's helpful. Their A1Cs go down, their weights go down, and the blood pressure goes down, the LDL goes down. So please initiate a referral to nutritional counseling at your institution. If you don't have nutritional counseling at your institution, we do provide this service through Vandalia Health. Vandalia Health has a virtual registered dietitian available to you. Her name is Stephanie Brumfield, and she will provide services to your patient either just with audio only over the telephone or audio visual. All you need to do is give us a call at this phone number here and fax a referral with a signature by a physician. It has to be a physician for Medicare. It can't be a nurse practitioner. It has to be a physician, and it has to be for a diagnosis of diabetes or renal disease, chronic kidney disease. And with that referral, we will actually do any kind of pre-authorization for commercial payers. And for Medicare, you don't even need a pre-authorization. So please get those referrals going, particularly for those patients who are not meeting the measure. Next slide. So from a provider point of view, what's an approach? I'm going to give you 2 references here. This one I really love. This is the American Association of Clinical Endocrinology approach to the algorithm for pharmacologic management of patients with diabetes. Next slide. And I'm going to give you the link to the website at the end. But basically what this does is it looks at lifestyle intervention, and then it looks at the whole patient, and it looks at each of the things that affect what type of pharmacologic management should be initiated in a patient who is poorly controlled and diabetic, and all the things that you need to take into account, including kidney function, other diseases. Next slide. And again, you can see how the algorithm works. Next slide. And even helps with how to initiate and titrate insulin, different types of insulin and GLP-1 medications. Next slide. These are the links to both the ACE guidelines, and then the second one is for the American Diabetic Association reference. Next slide. So how did we do? The next measure that we're going to talk about is hypertension. So there is a specific hypertension measure for diabetics, and we need to get their blood pressure systolic less than 140 and diastolic less than 90. And it has to be both of them, not just one or the other. Next slide. In the diabetic registry, once you drill down to your patient, this is what you would see. And you can see that this patient passed the measure because he had a blood pressure of 120/70 on February 28th. And you can see that this data is coming from my Millennium EHR. Next slide. So what about the diabetes guidelines? Well, I can tell you that the quality measure does not line up with the clinical guideline of less than 130/80. So ACE, ACC, and AHA all say that we should have our diabetics at 130/80, but our quality measure says 140/90. So that's what our recommendations and our registry will look at. So this is both an MSSP ACO measure and a HEDIS measure, both of them. And they just differ by age groups, basically. That's the only difference. The encounters are E&M visits, preventative visits, home visits, telehealth visits, but they do exclude if the patient has been in the ED that day, or if they've had a procedure, or if they've been an inpatient that day. You can exclude those visits, and they are automatically excluded. The inclusion in the numerator are the people who have had diabetes and have had hypertension during the first 6 months of the performance period. And they have to have, the blood pressure has to be both below 140 on the top and below 90 on the bottom. It has to be done by a clinician or automated BP device at the home or office. And it can be conveyed by RPM, and it can be conveyed by the patient if they're using a digital device from home. You can have multiple readings on the same day, and you can use the lowest systolic and the lowest diastolic. That means that your staff has to record repeat readings electronically so we can use the best of all of those readings. There are G codes that allow us to show what the readings were as well. We're going to go through how to deal with patients, how to deal with people who are not satisfying the measure. So exclusions, there are lots of exclusions, and they're very, very similar to the exclusions that you just heard for the diabetes, and you'll see them all listed here, and I'm not going to go through them all. The G codes for each of those corresponding exclusions are listed to the right. So again, if you're going to use a manual cheat sheet, you can see these G codes and you can use those. Next slide. So if your blood pressure is failing, what can you do? Well, you record it during the office visit. If it's meeting the measure, we're all happy. But if we're over on the right and it's not meeting the measure, either on the top or the bottom, the nurse can automatically flag that room. Either a flag, if you use a flag system on top of the door, or if you have a magnet to put on the door, or even a sticky note to put on the door to remind the nurse to go back and check that blood pressure again, because often 5 to 10 minutes later, when the patient has settled down, their pressure is better. If it's still abnormal, then the provider needs to take over and adjust the medication, the diet, and the exercise. And then follow-up needs to occur. So we either need to bring them back in 2 weeks and recheck their blood pressure in the office, or if they have a digital cuff at home, you could send a reminder to your nurse to have them call the patient at home and get a digital reading from home. If it's still above 140/90, then you can have them come back into the clinic for more intervention, do a telehealth visit for more intervention. There are lots of ways where you can feed right back into that loop until we get them in control. And remember, it's the last reading of the year. So your patient can be controlled all year long and then suddenly have an abnormal blood pressure. But you've got to keep it in mind at the end of the year, anybody who's got a bad blood pressure, try to get them back in or get another good blood pressure before the end of the year. Next slide. Okay, now we have to go on to eye exams, and I got to point out this is a really bad one for us. There's a lot of orange here. We need more blue. I am definitely going to say that in this one, I suspect that the problem is not that we aren't providing good care. I think that a lot of us are sending our patients for eye exams. I think we're having trouble showing this data in our records. So let's go on to the next slide. So what is the measure? It's a HEDIS measure this time. And again, these are E&M visits, ophthalmology visits, preventative health visits, and home visits. It includes people 18 to 75 who have diabetes. They need to have a retinal or eye exam by an eye care professional within the performance period, or a normal eye exam within the 12 months prior to the performance period. So basically, if I was going to say that in a different way, I would say that the patient has to have a normal eye exam. If they have a normal eye exam, they get a 2-year leeway. If they have an abnormal retinal exam, it's 1 year. They have to have it every year. So there's exclusions similar to what we had before. I'm not going to read through them. There's the G codes over to the right side. So what do we do if we're failing on the eye exam? Next slide. All right, was the exam performed? The first thing you got to do is go to your record. See, was the patient seen by a retinal specialist, or did somebody do a retinal photo? So, if all else fails, call the patient and say, hey, did you see the eye doctor this year? I thought we did. And a lot of them will know. They'll say, yeah, I saw so-and-so, but we never, you just never got the record. So that's the first thing to check is, was it done? If the answer is no, then you obviously need to refer to get the eye exam done. If the answer is no, you can also perform the retinal exam in your office if you are lucky enough to have a retinal camera. We do want to be careful here, though, because CMS has said that you cannot have your retinal photos read by AI. It has to be read by a real person. It has to be read by an ophthalmologist. Now, on the other side, on the right-hand side, if the retinal exam was performed and it's just not showing up in your quality measures, you have to ask yourself, okay, is the claim delayed? Because if this was done at an outside facility, it takes time for that claim to roll around back into healthy intent. And that's a possibility. So you can follow that case and see if it comes in a month or two, and if it still doesn't, I would go after it. You want to know, was it billed? There's a lot of things that you can look into. The second thing that you can do, if your EHR allows this, you can create specific document types. Now I'm going to explain this using kind of an example of, let's say you're in a neighborhood and you have to share one closet. Well, it would be really bad if everybody just shoved all their clothes in the closet willy-nilly and never had any kind of organization to it. No one would know where their clothes were, and they would have to search through everything in order to find their clothes. What you want in your scanning of your records is you want things organized into different sections and categories. So getting right down to the detail of having a document type that is specific for retinal exams, a diabetic retinal exam, that allows you to file it in the closet so that it's specific for diabetic retinal exams allows us to map it to the quality measure. So if you file a particular document and scan it to that doc type, we can make it map to that quality measure. So if you document, you also often have in the electronic health records, you also often have something called an electronic form, where you can grab this electronic form and fill it out to say that the eye exam was performed on X date and this was the result, normal or abnormal, and say that it was performed on that date. And that is also an electronic stamp of the fact that the eye exam was done on this diabetic patient. That's a second way to satisfy the measure. And then the third way is to go to your history section in your EHR and add retinal exam or retinal photo to that as a procedure in your histories, which has a certain ICD-10 code, and that can be mapped directly to the quality measure and say that you did it and this patient did it. All right. So this is how we fix the eye exam problem, because like I said, I have a feeling that a lot of us are over here on the right under yes, and we're just having difficulty showing the ACO that we did it and showing Medicare, yes, we did do the eye exam. Next slide. The last measure, well, second last measures that I want to talk about are the statin measures. And these are not easy, at least I don't think. We're doing pretty well, though. Okay, the middle one is the statin treatment for all groups. Now, all groups meaning this measure looks at not just diabetics. It looks at patients with hypertension. It looks at patients who have hyperlipidemia, familial cholesterol hyperlipidemia, and other patients that are labeled for treatment for statins, not just diabetics. And then there's the ones that are specific for diabetics on the right-hand side. And then they look at whether or not the patients were adhering to their treatment, and that's a HEDIS measure. So we'll go on to the next slide. So let's start with the ACO MSSP measure, which is the Medicare measure. This includes encounters for E&M, for preventative visits, home visits, telehealth visits, e-visits, and virtual check-ins. And as I said, you can see that the diabetics are just one in the several groups that are included in this measure. So it's diabetics 40 to 75. And as again, you can see that there are lots of exclusions, including breastfeeding, rhabdomyolysis, statin-associated muscle symptoms, myositis, allergies to statin medications, active liver disease, end-stage renal disease, and kind of nebulous medical reasons for not being prescribed statin therapy. And I'm thinking that that's more palliative care, hospice, etc. The HEDIS measure here is whether the patient is 40 to 75 and they don't have heart disease, and they want us to show that we've prescribed the medication and that the patient has picked it up and has been taking it at least 80% of the performance period. So we have to prescribe it, they have to pick it up. So the first one is an EHR data piece, and the second part is a claims piece. And that's important to realize that the first part is your EHR piece, the second part is the claims piece. All right, next slide. So if you find that your patient is failing the statin measure, first thing to know is, are they on a statin? If they're 40 to 75 and diabetic, are they on a statin? If the answer is no, consider starting a statin. If you don't think if there's no contraindication, please start a statin. If there is a contraindication, document the contraindication with an ICD-10 code. Katie, thank you for reminding me of this. This must be documented yearly. You have to put that ICD-10 diagnosis in one of your visits every year. You can't just do it once and forget about it. You have to actually you have to put that in there every year. Okay. And now diabetes, if they are on a statin and it's still failing the measure, you have to look and see if they're compliant. If they're not compliant, you need to counsel them. And I will tell you that the problem I found, I had some where I dug deep on these, and what I found is that if I wrote a prescription on December 15th for 90 days with 3 refills on my lipids, so, to decrease my inbox problem. The issue was that if my patient was just a little bit non-compliant and missed their meds some, it was possible for me not to have prescribed it for a whole year. And therefore, I did not, in my EHR, it showed no sign that I prescribed it in 2023. So what I've done for my lipids and my hypertensive meds and my diabetic meds, I have changed the prescribing to 90 with 1 refill, which is a pain, but at least it shows that I am compliant from an EHR point of view. Next slide. There's one last measure that we need to talk about, and that is kidney health for diabetic patients, and this is a HEDIS measure. This is new for 2024 in that it's specific for the having an estimated GFR and a microalbumin of the urine, microalbumin creatinine ratio once in the performance period. And this has nothing to do with whether or not they are on an ACE or an ARB. It's separated from that. So right now, we don't have a registry measure that is separate for that. And we have reached out to Cerner Oracle to address this, and we'll get back to you about how to identify these people. I would ask that the providers and staff that when you see diabetic patients, just make sure that they have had a microalbumin in 2024. It doesn't have, you don't have to wait a full year. You can actually do one in 2024 if they haven't had one, get it out of the way so that this measure is covered. All right, next slide. So just some general methods to close gaps. Number one, you need a plan. So the plan might be slightly different in your clinic compared to every other clinic. It might be different for one provider to another provider, but you won't get where you need to be without a plan. So the first step is to make sure that you have a plan, and that plan needs to be team-based. You cannot do this by yourself as a provider. You can't do it by yourself as a clinical staff person, and you most certainly can't do it by yourself as a manager. So I would encourage you to get together as a team and make a plan. The first step is in the front office. Front office staff, if you can schedule these people for chronic disease management every 3 to 4 months, and make sure that every patient who has chronic disease is scheduled that way and has an AWV on the books with every discharge from every clinic. Pre-charting is a big deal. If you have any time to pre-chart on these chronic disease management patients, to identify those people using your point of care reports or your healthy intent work lists to figure out which patients are not meeting measure and which ones need to have these things done at the next visit. And maybe even propose those orders to your providers prior to the visit to get them done. And as I said, if you are finding it really difficult with your EHR because it doesn't have capability to do some of these things, then there's always the opportunity to create a manual cheat sheet and use the G codes to show what you've done and what your patients have done. Next slide. What I'm going to tell you is that it is hard and it takes a lot of doing, but as you get better at it, as you use your plan and you use your knowledge, you're going to find that not only your team is going to be as happy as these little guys, but your patients are going to be happy because they're going to feel better. Their health is going to be better. And I'll tell you that the people at the ACO will also look like this. Next slide. So any questions? We have about 15 minutes to talk about questions. And Katie Lanham and Andre Strobridge, I would just want to say thank you to both of you who helped me put the slide deck together and gave feedback on what we should say. So they are both here today too to answer questions as well.
It looked like there was a couple questions in the chat from earlier.
Is there a goal that is set for each of those measures? So this is a really good question because I asked this too. So you're asking about a benchmark. So Michelle, this is an issue for the MSSP ACO measures. The unfortunate thing is that we don't know what our benchmark is going to be until I guess Katie, maybe you can answer this question better than I can, but it's not early in the year that we know. We don't know until after. So for 2023, we don't know until 2024 what the benchmark is. And that doesn't seem fair, right? we don't know. Katie, do you want to comment on that?
Sure. Yeah, for our ACO population, it is a little bit of a retrospective review, meaning, we really don't know. We don't have full transparency into what goal we're trying to reach throughout the year. With our other payers that we have value-based agreements with, they do give us a specific goal. It usually falls in line with a percentile as defined by NCQA. So some payers use the 50th percentile for a particular measure. Some define it as the 66th, for example. And then the practice transformation team here at the network has a few little cheat sheets, honestly, that go through each value-based agreement with each payer, and will translate that percentile into a percentage goal. If you're like me, you can say, okay, my goal is the 50th percentile, but I don't know what percent that is unless somebody discloses that to me. So we try to share that information with all of our practices.
And with that, it's hard to put. So for a HEDIS measure, like for example, the microalbumin creatinine ratio, it would be nice if we could actually draw a line on that one and say you need to get to 60%. But the problem is that what Katie's saying is that Aetna might have a different line than say United Health Care.
Right.
So that's what makes it difficult for us to tell you where you need to get to. All right. It may be helpful if the ophthalmology locations join the state West Virginia Health Information Network. If it's possible, the records would be easier to impart on a larger scale. I agree with you, Linda. I was just talking to them yesterday, and we're talking about all kinds of ways that we could get more information into the West Virginia Health Network, or West Virginia Health Information Network. And if people are wondering what that is, the West Virginia Health Information Network is our local HIE, which is the Health Information Exchange, which is connected to what we call a QHIN. And the QHIN is connected to TEFCA, which is connected to Sequoia, which is supposed to be eventually where all the patient's health information is connected to one big circuit, so that eventually everyone will have the same information. And we're hoping that this is going to happen. I agree, Linda, that would be the best thing. And we'll work towards that. Does documenting in the recommendation section in Cerner not adequately update the chart for eye exams to qualify? So on health maintenance tab, Brandon, this does not work because you're just saying that it was done. You're not showing data that CMS needs to show that the data that it was actually done. So what has to happen there is that you need to have somebody in your office actually obtain the data, which is if it's an outside facility, you need to have the report, and then that report needs to be scanned under the diabetic retinal exam doc type. Or you can use the electronic power form for diabetic eye exam and put in the performance date and also whether it was positive or negative, and it would satisfy the measure. Or you can use the procedure code in the history section, and your nurses can do this as well. You don't need to do it, but your nurses can do it. So you can send a message to a nurse and ask them to track it down. That's what I do.
Yeah, hey doc, I mean, we get the records, and then as soon as I get the records, I'm documenting the dates of those services in the health recommendations section. So, I mean, I'll be honest, I'm not going to take the time to do all this other stuff. So this has got to be a staff level thing to do.
That's right. Yeah, and that's what I would do. And if you see that it's missing, I think if you can just do a quick message to one of your staff and have them track it down. And as long as they're trained on how to make it work, then they can use any one of those 3 methods to make it work. And eye exam is you can see why we're having trouble. And that's why I'm saying, I think you're doing the work. It's not getting transmitted by data. At Davis Medical Center, we also have an RD that's wonderful. I know we are not on Cerner Millennium yet, but we are getting closer every day. That's wonderful. I would love to know who that virtual nutritionist is, and so we can connect. So if somebody would send me, Tiffany, if you would send me that name, that would be great. Brandon, I'll just want to clarify, random urine microalbumin does not qualify. According to the HEDIS measure, it was specific about microalbumin creatinine ratio. We also have an ophthalmologist that is starting at Davis. Her the first patients today. Excellent. Another good referral source. And Katie, wonderful opportunity to share resources throughout the network. That's great. And we will send information on referral forms. Excellent. Anybody have any other questions? All right. Thanks, everybody. Recording should be on the website. And good luck with closing your gaps.
Thank you
Bye-bye.
so much, Dr. Lohuis, and thanks everyone for joining. Have a good rest of your day.
You too. Bye-bye.
Thank you.
Bye-bye.
Thank you.